Well, good afternoon, everyone. It's hard to come out third in this group of speakers, and look forward to hopefully sharing some information with you. And as we kind of move from the microcarcinoma earliest tumors to those that are now intermediate, now to the most advanced tumors that would not be patients that we would be typically thinking about radioiodine therapy in general. Let's see if we can get this. There we go. So no disclosures. So when I think about thyroid cancer, or in fact this could be any cancer, you have a primary tumor, which is depicted here on the left, cells that either get marked through their genomic changes or through epigenetic changes to invade into the blood vessel, go into a distant site such as the lungs, and either have a short dormancy, in this setting, something like anaplastic thyroid cancer, where tumors are very active, metastasize, and grow very quickly, or the more common situation where they metastasize as differentiated cells and have a long dormancy because that's their basic biology. It's our belief in our lab, and I think in most people around the world now, that metastatic progression, when it occurs early. You remove the primary tumor, maybe you do or don't, give remnant ablation, but the microscopic tissues that you see in the lungs don't magically appear later. They've probably been there at the time you were diagnosed, but just below the limit of your clinical detection. So we're going to talk about these different locations and areas in the time of progression and how we might apply them and how they are being applied to thyroid cancer. So let's see. So first we're going to talk about the early stages of the tumor. So let's first talk about TCGA. You guys have seen these slides a number of times. Tom Giordano gave a fantastic talk on this yesterday. I was lucky enough to be part of this working group leading the signal transduction component with Jimmy Fagan. What I want to make sure people understand about this data set, because there's a lot of talk at this meeting and many others of expanding this beyond the clinical setting from which these tumors represent. So I want to talk about this briefly. So these are primary thyroid cancers. These were selected, and this was an argument that I lost, okay? These were selected to be only well-differentiated thyroid cancers. These are the exact tumors that you heard about from Dr. Miauchi and you heard about from Dr. Piccini. These are the well-differentiated thyroid cancers. These were relatively early-stage tumors. This was done so that there would be enough tumors so that we could make some statistical headway with the data. They were right and I was wrong, but it was really an important thing to understand. These were samples from the central part of the tumors. For those of us who do cancer biology, we know that the central part of the tumors are the quietest part of the tumors. They do not interact much with the microenvironment. So this was also done on purpose to get a clean genetic picture. There were no follicular cancers. This entire data set, unless you're going to start saying that RAS mutated follicular variants are follicular cancer, and people know I believe that, but we're not saying that yet. These are papillary thyroid cancers, which may or may not represent. There were 11 cases out of the 500 that had distant metastasis. So statistically, if you're going to use this data set to say you're predicting metastasis, I would argue that you cannot. Okay, and I think that that's very clear. There are lymph node metastases, but not distant metastases. So this is the big data. You've seen this a number of times already. The big news here is dealing with well-differentiated small thyroid cancers. They're quiet enough genomically that you can actually separate BRAF from RAS at all components. So what you can see is you have your BRAF-like tumors here. They look very similar. They cluster not only in terms of their mutation, they cluster in terms of DNA methylation, they cluster in terms of histology as classical papillary cancer, they cluster in terms of RNA sequencing. The RAS-like tumors cluster here, and they cluster together. Okay, so this was the beauty of this study. It's the first large data set where you can truly separate these out. You got a group of tumors then that fall in this group that had some uncommon mutations in this setting. I'm not going to talk about these in more detail, but suffice it to say that some of these are actually more common and poorly differentiated tumors, can be seen at a higher incidence in those, but not in this data set. So let's talk about then the predictors that you might have. Okay, we have a lot of doctors in the room. We know most of these patients when they hit the office, right? So these are older patients. They're more commonly male. They tend to have larger tumors, the rock-hard solid tumors. These are the ones when you follow, they may grow. They may have vascular invasion, oftentimes gross local invasion on pathology. If they have distant metastases, you know the ones that you worry about the most are the ones that are not 20 years old with micrometastases. There's the patients that are my age, older, that have larger metastases, bone metastases, brain metastases. These are the patients that we're going to worry about. We don't necessarily need a molecular test to tell us who the patients are. We might want a molecular test to tell us how to treat the patient. We know we're worried about them if they've got poorly differentiated or anaplastic cancer as well. So the question is, can you apply the TCGA data that are showing you early driver mutations to this population in a cogent way? So, BRAF V600E, let's talk about this for a moment, okay? BRAF V600E is definitely associated, if you look at large populations, with more aggressive features. We've heard this through the meeting, and it's correct, without question, in almost all studies. And if you look at clinical trial populations of patients with papillary cancer, it is enriched. And we published that in the first phase 2 sorafenib study, demonstrating that 80% of those patients have a BRAF V600E mutation. However, while there are quite a bit of data to show that it is an univariate analysis associated with poor outcomes, if you do multivariate analysis of most of these studies, in fact, it's not independent. Okay, so we do think it's important, but it may or may not be independent of the clinical features I showed on the prior slide, where we know who these people are. So why might that be? Well, we know that it's just so common, right? We've just seen the data that these patients do well. 98%, 97%, 99%, 40 to 50% of those patients will have a BRAF mutation in the United States or in Europe. 80% will have it in Asia, okay? So if BRAF itself is that bad, wouldn't you expect people to be doing worse, right? So if you apply it to the general population, it's probably not that important from a prognostic perspective for an individual patient alone. Not that it can't be included in a panel, but not alone. And there's really no evidence that the BRAF V600E mutant microcarcinomas behave dramatically worse. And I know there are those in the room who are working on this right now. It might predict statistically in a small percent that that's the case, but on an individual patient, you're in front of me with the patient, it's not like patients with 4-millimeter papillary cancers are dying. We saw things of patients for 50 years with 0 cancer-related deaths, okay? So we've got to keep this in context. So in my mind, the data with recurrence predicted by BRAF V600E is predicting a subpopulation, and that subpopulation is selected for the BRAF V600E plus. And we're going to talk about what that plus probably is, but not BRAF V600E alone. And the problem is all the old data that we've been looking at only looked at BRAF V600E, didn't look at the pluses. Now we're getting that information, and I think we're going to be able to see that answer, and then we might be able to get the predictor that we need. RAS mutations are associated with distant metastases in patients that are selected that have follicular thyroid cancer. And these are data generated from Sloan Kettering that I have there, but there are more. However, this is also found in benign nodules. So again, it's not going to be RAS alone, it's going to be RAS plus. Does that make sense? Okay. So what's the plus? Well, here's the one that's probably been the best studied, and these are TERT promoter mutations. And TERT promoter mutations are not in the coding gene. So if you just do RNA, if you do exome sequencing or something like that, you will not see these mutations. These are in the promoter to the gene, okay? They improve the maintenance of the expression levels of TERT. So they then cause increased expression of telomerase, which if you remember from 15, 20 years ago, we were using to try to separate follicular carcinoma from adenoma on FNA. Same concept, just then there's a mutation, and Mingxiao Xing's group has published some very nice work showing a mechanism for the BRAF V600E plus TERT. There are a number of papers that show that this, in fact, does appear to be an independent predictor of worse outcome. It's just harder to screen for. So in the United States, at least, some of the genetic companies that we're using are screening for this as a routine in thyroid cancers. So I think there's more to come on this, but really be careful when you're just looking at BRAF V600E alone, because I don't think the bulk of the data is supported at this point, in my opinion. And if you want to throw something at me later, feel free. It's fine. Okay, so let's now talk about targeting progressive thyroid cancer. So let's again focus early. Here is what is FDA approved in red in the United States. I'm not sure exactly what's available in the country that you're in, and this is a list of the targets. I have got lenvatinib and sorafenib underlined because they're the two that are approved for progressive differentiated thyroid cancer, which is the focus of today's talk. And what I want you to point out is that other than a few, like dabrafenib and vemurafenib or LOXO-292 and BLU-667, those that have been best studied in thyroid cancer that we'll talk about are multi-kinase inhibitors, meaning they are not specific inhibitors, okay? So they're not perfectly targeted drugs, at least the early ones I'll talk to you about. So there are two studies, I'm showing you data from the phase 3 studies. You guys have seen these already. I want to point out two features of these studies. This is sorafenib, the phase 3 study published with Marcia Brose as the first author, demonstrating what they first show, which are the what are called waterfall plots, which is the best tumor response. These are the treated patients. These are the placebo patients. But when you look at the curves, you can see that the slope is slightly different. Most of that occurs here. And this got the FDA approval in the United States. It's just a few months of difference in this. And I want you to look at the control population, because this was an early study showing low rates of progression in the placebo population. If you compare that now to the lenvatinib study, which most of us view as the first-line study, this is not a comparable control population. We got smarter in terms of enrolling. This is a sicker group of patients. Remember, I showed you that placebo before that kind of looked like this? This placebo is really sick. Right? These are patients that are dying over a few years with their cancer. And you can see you get this big effect here with lenvatinib. And the NCCN guidelines last year came out with a clear statement that lenvatinib, at least in the United States, is the drug of first choice for these patients. Okay? But remember, they've not been compared head-to-head in a population that's the same. Okay? So all that is a little bit of conjecture as well. Okay, BRAF V600E inhibitors. This is data that was published again by Marcia, demonstrating patients with progressive differentiated thyroid cancer, showing the majority that had a BRAF V600E mutation did have a response rate that was moderate in this study. We've separately done a study at our place and at others that was headed by Manisha Shah, demonstrating that BRAF in well-differentiated thyroid cancers or non-anaplastic thyroid cancers, there is no advantage of combining it with a MEK inhibitor, which is not expected. Okay, so at least in this situation, different from anaplastic cancer, BRAF V600E inhibition alone is just as good. And this is a case for one of the early, if not first case reports of an anaplastic cancer patient with a response that was really quite dramatic, transient but quite dramatic to this therapy. All of this then led to this study from Subia, a combined study from MD Anderson and South Korea in patients with anaplastic thyroid cancer. I'm not going to go over it in detail because we'll talk about it more tomorrow or later in the meeting, but demonstrating really impressive responses. And this has changed clinical practice in the United States. If you have anaplastic cancer, you will, in most centers, get a BRAF V600E mutation screen to see whether you should go on this as your first-line therapy. Okay, nothing's perfect. Resistance to these is universal in my experience and in most. This is true for the BRAF V600E inhibitors, and we've demonstrated, and others have demonstrated acquired mutations in KRAS, which are hard to target, RAC1, which we're very interested in my lab, which I won't go over today, EMT mediated by CMET as well. They also have side effects. Despite having less side effects than other chemotherapies, patients know they're on a medication, and it's not always perfect. So let's now move to the last part of the talk, which is moving into the metastatic environment, which is really where we're most interested in my lab because this is when we see patients. We see patients with progressive metastatic disease. Immune checkpoint inhibitors, Brian Haugen's going to talk more about this in his, I think, 3-minute talk, or is it a 10-minute talk tomorrow? But I think you'll have a little bit of time in the panel. Looking at immunotherapy, there are ongoing studies. He's the head of one big one in the United States with a combined lenvatinib pembrolizumab study. It can be predicted by genomic instability or by overexpression of PD-1 and PD-L1. This is very uncommon in progressive differentiated thyroid cancer. If you look at the pathology literature, it would say that this can occur in 50% of cases. I have almost never seen it in my practice. I don't know if others in the room have when we screen. It is not common until you're in an anaplastic cancer setting, in my experience. Okay, here's some of the early data. This was published in just last year, looking at adding essentially pembrolizumab to a kinase inhibitor as a salvage therapy and showing some benefit in a subgroup. And these were the chemotherapies the patients were on. Again, this is from MD Anderson's group, demonstrating potentially some benefit. So I said we were very interested in getting to the distant metastasis. I've been pushing ITOG now for a few years on this as well, that we really get very aggressive about biopsying distant metastases to understand their genomics. This is very important because if you're a patient, you want to be targeting the growing tumor, not what was taken out 10 years ago. When I presented that way to patients, they almost always are happy to have a biopsy, even if it means a lung or a liver biopsy or a bone biopsy, so we understand what we're treating. And we think this is extremely important and obviously can be both cell autonomous or microenvironment. So we did a study, a small study a few years ago, characterizing a number of these metastatic tissues. This was combined with Tom Giordano. He showed you one slide on this yesterday. This was 19 samples from 11 patients. All patients had been heavily pretreated just with radioactive iodine. No patients had previously been on kinase inhibitors, and there were a couple patients with anaplastic cancer that had derived from papillary cancer. We did a 682 custom next-generation panel that at that point comprised all known cancer genes. It included all of their promoters and included about half of the introns as well as microRNA processing genes. And we did MIR-seq, and I'm not showing you the MIR-seq data today. Here's the bottom line data. And what it shows, and the action here, is that if you had a BRAF or a RAS mutation in the primary tumor, we saw those in the distant mets. We did see a couple of other things. But if you didn't have those mutations, you almost always saw mutations in these two genes, which are ATM and ERCC4. Now, why is that? Well, it turns out ATM is a tumor suppressor gene. It causes ataxia telangiectasia, but really what it does is it regulates DNA damage repair and DNA damage repair and telomere stability. ERCC4 is also a tumor suppressor gene that also regulates DNA nucleotide excision repair, which is involved in DNA damage response. They were both mutually exclusive, as I mentioned, and ERCC4 always co-occurred with ATM, and we and others have now shown that this combination of mutations and loss predicts synthetic lethality to ATR kinase inhibitors, which we're studying actively right now in vitro and in vivo. So we think this DNA damage repair genetic change is very important, whether it's induced with prior therapy or whether it was there in some subset of the initial cells, we do not know yet. Okay, last thing we're going to talk about when we're considering metastatic progression is, remember I told you in long dormancy thyroid cancer, what's different about these tumors compared to most is that they maintain metastatic dormancy for decades. We have all, and we can raise our hands, have had patients who've had lung metastases for 30 years that have not grown. Their thyroglobulins don't budge. Furio's given them 5,000 millicuries of radioiodine when he was younger in divided doses at 150 millicuries every year, something like that. But they just stay stable, and they come back year after year. And that is not typical, right? But it tells you something important about the biology. It tells you that their growth is normally restrained. So you can look for new oncogenes to develop, or you can say, what's the break that's being lost? So we've looked at the opposite. We've looked a little bit about what that break would be being lost. And I'm just going to show you two slides from a fairly recent paper with a new, what's called a metastasis suppressor that we identified called RCAN14. I won't show you all the human data. This was about 5 years of work leading into this. This is just some mouse studies where we took cells, thyroid cancer cells that have high levels of this normal basally that don't metastasize in mice. We knock out the gene. You can see that these grow quite dramatically differently. These are just xenografts. These are the curves. These were highly statistically significant. And this is now looking at a metastatic model. This is now looking at lung mets. We don't see any. When you have the gene, we see it in almost all mice when we knock it out. These are the statistics. It was very dramatic, and these are what some of the lung mets look like. We did a whole lot of microarray work and subsequent functional studies to try to understand why this happens, and we identified a single gene that we think is most important, and I'll be done in a moment, called NRF3. NRF3 is in a cluster of transcription factors called the NRF transcription factors that are in the 20 most mutated genes amongst all cancers, okay? NRF3 had not been looked at. And what we showed in thyroid cancer, not only did it rescue and block the effect, but in TCGA with these well-differentiated tumors, we see an increase in NRF3 levels. If we look across, now these are our own samples, normal tumor, invasive front, and metastases, it goes up. I'm going to get more dings. So you can see it's associated with progressive thyroid cancer. So what I've told you is you can target initially these early genes, you'll get resistance, but you can get sometimes really dramatic initial responses in selected patients. It's worthwhile doing because we get good responses. But that's not going to solve the problem, okay? In addition to that, we need to focus on things like DNA damage repair, things like new mutations that may be occurring at